Good evening, everyone. This is Vinny Francio. I'm a co-chair of the Aspen Young Innovators Committee. I'd like to welcome everyone to tonight's Journal Club on the Aspen Best Practice Guidelines on the Diagnosis and Treatment of Vertebrogenic Pain. I'll be moderating tonight's Journal Club with Dr. Harman Chopra. Dr. Chopra, take it away.
Good evening, everyone. Thank you for joining us in this wonderful month of March. As you all know, it is Women's History Month, so we thought it'd be only appropriate if we have four outstanding women physicians in the field present this topic to us. To begin, we have Dr. Kiran Patel, Program Director at Northwell, who is well known in the field and needs no introduction, but I will anyways. Thank you for joining us from New York, Dr. Patel. Dr. Eileen Padilla, current interventional pain attending based out in Toledo, Ohio. Thank you for joining us. And we have two trainees, Dr. Alexa Morera, who many of you know is currently doing a social media stint with Dr. Lady Spine Doc and is currently a Rush Pain Fellow. And we have Dr. Tanya Janeja, currently a PGY2, soon to be 3 at Johns Hopkins PM&R. And we are excited to have this wonderful topic being discussed by some of the most impactful and stellar physicians. So without further ado, I'd like to ask all the attendees to keep any questions you have ready for the chat. We will go through them as we can, and for all the panelists to turn off your camera and let the two young physicians, Dr. Morera and Dr. Janeja, take it away. And without further ado, let's get this going.
Hi, everybody. I'm Tanya. I'm a current PGY2 at Hopkins, and I'm really excited to be here and be presenting. We can start off with the next slide. There are no conflicts of interest involved in this presentation. These guidelines were authored by practicing attending physicians with expertise within the field of interventional pain. And we can go ahead and go to the next slide. So basivertebral nerve ablation is a targeted intervention designed specifically for patients with vertebrogenic pain, which is defined by the Aspen guidelines, which we'll be talking about. What distinguishes vertebrogenic pain is that it has clear anatomic and radiologic evidence, namely modic type 1 and modic type 2 changes at the vertebral end plates on MRI, which we'll talk more about in a little bit. And these modic changes are more than just imaging findings. They represent active inflammatory processes at the end plates that sensitizes the basivertebral nerve, and it makes it a pain generator. And before these guidelines, vertebrogenic pain was often misclassified as nonspecific low back pain, and this kind of led to inconsistent guidelines and diagnoses, which furthermore led to more ineffective management. The Aspen guidelines really aid to fill this gap by formally recognizing vertebrogenic pain as a distinct clinical entity, and this provides more clear diagnostic criteria, and it supports the BVN ablation as an evidence-based treatment, which is supported by level 1 data as well. We can go to the next slide. The basivertebral nerve branches off of the sinovertebral node, and it travels through the central foramen into the vertebral body, which we can kind of see demonstrated in this photo. It sends fibers directly to the superior and inferior end plates, and this is exactly why damage to the end plates can trigger chronic pain. The BVN fibers are nociceptive, which means they can transmit pain signals. So when these end plates get inflamed or injured, the nerve becomes the primary pain generator. The end plates also do more than just hold the disc in place. The end plates also help absorb and kind of distribute pressure across the disc space, which acts kind of like a shock absorber. They also serve as the disc nutrient gateway, since the disc itself the disc itself is avascular, so it relies on diffusion from the segmental arteries via the end plate. So when the end plates break down or they become inflamed, it's not really just a structural issue, it's a pain problem, and it's happening at the site of that the BVN nerve directly innervates. We can go to the next slide. For our methods and evidence quality, the strength of our guidelines lies in the quality of the evidence. They're grounded in multiple randomized controlled trials, systematic reviews, and real-world observational studies as well. All of these studies did use MRI confirmed modic type 1 and type 2 changes as inclusion criteria. So our patient selection was very precise. There were some limitations to these studies. Certain studies had smaller sample sizes or were industry sponsored, which means that we have to interpret these studies with appropriate caution as well. That being said, recommendations are backed by level 1 evidence, including multiple randomized control studies supporting both BVN as a pain generator and BVN ablation as a valid and effective intervention. Level 2 and 3 studies were also used to sort of strengthen long-term outcomes and clinical reasoning, especially when randomized controlled studies weren't feasible. We can go to the next slide. So our next slide talks about the pathophysiology of BVN pain. The vertebral end plates are highly innervated, and this makes them very vulnerable to damage, especially with aging, trauma, or inflammation. As the end plates degrade, whether it's due to calcifications, microfractures, or interosseous edema, they trigger an inflammatory response that you can kind of see depicted here with the IL-6 and the TNF alpha. So this whole inflammation leads to the release of pro-inflammatory and neurogenic factors, and this will stimulate the growth and sensitization of the basovertebral nerve findings. The result of this is a local proliferation of pain-sensing nerves, and that's exactly where the compressive forces are being absorbed, and that turns into a mechanical load, which also will lead to a chronic pain signal. And in patients with modic changes, the pain is being generated within the vertebral body itself, not from a compressed nerve root that we might see in other sources of pain, such as sciatica, which represents a different source of pain that requires a very different diagnostic and treatment approach. We can go to the next slide. So this slide really talks about the modic changes that we see. When we talk about the vertebrogenic pain, one of the radiographic changes we see are the modic changes, and they're markers that reflect what's happening at the end plate level. So with modic type 1 changes, they are associated with acute degeneration, and they show up as low signal on T1 and high signal on T2, and this corresponds to active inflammation and edema. Type 2 changes represent a more chronic or subacute degeneration, and you see fat infiltration that's likely due to ischemia, and both T1 and T2 will appear hyperintense. Patients with modic type 1 and type 2 changes are the ones who will best respond to the basovertebral nerve ablation. So identifying the changes on MRI is also about selecting the right patient population for the right treatment. We can go to the next slide. So when we evaluate vertebrogenic pain, we're connecting two things together. So a very specific clinical picture and confirmatory imaging findings. Clinically, patients describe this pain as deep, aching, and even burning. It tends to flare with sitting, twisting, moving forward, sitting to standing positioning. And that's because a lot of these movements will load the vertebral end plates. On physical exam, percussion tenderness and pain with flexion-based movements are key reproducible signs. We also match with this with imaging as well. The modic type 1 and type 2 changes on MRI that we talked about previously, and other supportive findings are Shimori nodes, end plate disruption on CT, and increased radiotracer uptake on CT, and all of this points to inflamed and reactive vertebral body. We can go to the next slide. So on the next slide, we talk about the basovertebral nerve ablation. So it's an FDA-approved treatment for treating vertebrogenic pain, specifically at the L3 to S1 levels, where modic changes are commonly observed. Patients must meet strict criteria, which includes axial low back pain lasting more than 6 months with MRI confirmed modic type 1 or type 2 changes, and a failure to respond to conservative non-surgical management such as NSAIDs, physical therapy, or activity modification. The FDA approval is based on level 1 evidence from randomized control trials, which demonstrates statistically and clinically significant improvements in pain and function. And we'll talk about the studies in subsequent slides as well. And by aligning the patient selection with the evidence-based criteria, we can avoid overtreatment in the wrong population and actually deliver relief to patients who are most likely to reap the benefits from this procedure. And we can go to the next slide.
Great job. So I'm going to kind of jump right into the procedural aspect of this Intercept procedure. Basically, you see here an image, an AP image of the approach. There are an apiolateral approach as well as an oblique approach that some attendings will do using either a diamond tip trocar or a bevel tip. Here you can see an image using a bevel tip going from medial to lateral. Lateral to medial approach on the pedicle border and traversing through the pedicle of the lumbar vertebral bodies. Next slide, please. And here is a lateral image of that. Same approach with a bevel trocar tip. You're advancing this with a mallet 1 to 2 millimeters at a time, checking your views in lateral. Go ahead and the next slide, please. And the ideal placement of this bipolar radio frequency probe would be basically saddling the spinous process, as you can see there in the AP view, where that's the final placement of the J stylet tip in the lumbar vertebra. And then there's a lateral view here to the right showing that probe deployed after removing the trocar and placing in the cannula with the probe in it. And then this procedure is recommended for a 15-minute burn. Some also can do a 7-minute burn. And I'm sure our attendings can give their pearls and what their experiences have been with each types, but heating up the probe, the bipolar probe that's made of ninitol at 85 degrees centigrade for a 15-minute burn. Next slide, please. And really quickly, I thought this was an awesome slide that I found on a summary website, essentially on the company's website, essentially going from baseline to 5-year data showing 60% of patients endorsing a decrease in their ODI at 5 years, and that's a sustained relief. So the original SMART trial with 128 patients was followed through 5 years, showing significant improvement in VAS and ODI scores. And we'll kind of get more into that in a little bit. And we'll have our attendings kind of talk about the key pearls and challenges seen with this type of procedure. Next slide, please. So future directions, BVN ablation can be used to treat vertebrogenic pain. BVN pain is recognized as a contributor to chronic low back pain in a unique subset of patients. Proper diagnosis per Aspen criteria is essential for targeted treatment. There is ongoing research expanding treatment options for vertebrogenic pain. Limitations do include that there's limited long-term efficacy data on BVN ablation, requiring more longitudinal studies and randomized control trials. Future research should include alternative treatment pathways for patients with motor changes who do not respond to BVN ablation. Also, just limitations with the procedure itself can be found with any type of like kyphoplasty, for example, and sacroplasty. Narrow pedicles can limit this type of procedure, which is getting access into the vertebral bodies, and whether or not basically does this put people at higher risk for compression fractures in the future. You know, there's research by Dr. Beal that will kind of shed light on that. But I won't steal the thunder from our attendings who are going to share some more pearls about this procedure. And with that, I'll introduce Dr. Padilla, who will take it from here. Thanks.
I think you're on mute, Dr. Padilla.
Thank you. All right, well, thanks again to Dr. Moreira and Dr. Francio. Good evening, everyone. I'm Dr. Padilla. I'm currently part of a private practice in Toledo, Ohio, and I have been using BVNA in my clinical practice for the past 4 years. I will be going through 2 cases and talking about how you can incorporate the ASPEN guidelines into your clinical practice. So this first case, we have a 70-year-old male who had low back pain for over 5 years. It started gradually, and he says the pain is worse with tying his shoes, reaching overhead, sitting and standing for long periods of time, and getting up from a chair. The pain was better with ice and heat. He describes it as stiff, achy, and worse in the morning. He denied any radicular symptoms, so there's no numbness, weakness, tingling, no heaviness in the legs. The pain was 7 out of 10 in severity on average, and he had already completed physical therapy. Next slide. So after hearing that, at this point, like before I even examined the patient, I'm thinking, okay, he has no radicular symptoms and no symptoms of neurogenic intermittent claudication. So it's unlikely that he has a problem in the middle column of the spine. But after that, it kind of looks like he has a mix of possible pain generators. So if you remember, he said reaching overhead and standing for long periods of time gives him pain, as well as having stiffness and achiness, especially in the morning. That points a little more towards posterior column pain, because with those extension movements of his spine, he complains of pain. But then he also says that with tying his shoes, prolonged sitting, getting up from a chair, he has pain as well. So that stresses more the anterior column. So looking at the ASPEN clinical guidelines, where do you go from here if he has multiple pain generators? Next slide. So after talking with the patient, we decided to pursue treating his posterior column pain first. We ended up doing a bilateral L4-5, L5-S1 lumbar RFA, and that did end up improving the stiffness in the back, and his extension-based exercises or activities ended up improving. But he was still having a constant nagging, like achy pain, sharper on the left side of his low back, but again, the anterior column stressors, the bending to put on his pants, tie his shoes, getting up from a seated position, prolonged sitting, were still giving him significant pain that he wanted to keep pursuing different treatments. Next slide. So these are 2 sagittal cuts of his MRI, T2 on the left, T1 on the right. You can see there are prominent L2 and L3 modic type 1 changes. If you look closely, he also does have some subtle modic type 2 changes at L3-4. and also very subtle at the superior end plate of L5. And on physical exam, the patient had tenderness to palpation in midline at all of these levels. So because he kind of had pain throughout and did have even mild modic changes at those levels, I decided to go ahead and do BVNA from L2 to L5. Next slide. So these next few slides are his procedure pictures. It was fairly straightforward. You can see on that AP picture on the left, he does have nice sized pedicles. He does have some scoliosis at L2 and L3, so getting a good lateral fluoro picture at those levels is key for your positioning. Also, for a patient with scoliosis, they'll usually enter at the convex side of the curve, so you're less likely to encounter sclerotic bone. Next slide. At L4 and L5, there wasn't much scoliosis, so typically you'll enter from contralateral pedicles, just so your instruments are not running into each other. Dr. Moreira talked about entering either an AP or an oblique, and I'm an oblique en face kind of person, but that just depends on your comfort level with the procedure. Next slide. And that's just the placement of the probe for L5. Next slide. Okay. So this patient ended up doing really well. He had 70% improvements after his BVNA and no longer was complaining of that pain with the lower body dressing. He had less pain with prolonged sitting, still had some morning stiffness, but was able to easily relax by stretching every morning. So he was pretty happy with his functional status after doing BVNA. Next slide. All right, so this next case was a little more challenging. This was a 50-year-old male who came to see me for a second opinion. He had already been having pain for over 30 years. He states it started after he blew a disc out. He had undergone 11 lumbar surgeries. He also ended up with a bilateral SI fusion. He had an SCS implanted with an IPG that was swapped. They tried reprogramming without any relief of his back pain. He actually stopped using the SCS for the last few years. Of course, he had tried physical therapy, aquatherapy, dry needling, cupping, chiropractic care. He was very motivated to try and improve his functional ability. He had tried cuddle, epidurals. He also had SI joint RFAs, which did give him some relief. But when I saw him, his biggest complaint was just a constant, he called it a crushing, dense pressure in his low back. And he said it was worse with bending, with twisting, with standing, but the pain was constant. It was burning, always there. And that's what made me think about vertebrogenic low back pain for him. Next slide. So this was his MRI. And when I first saw this, I was like, okay, where do I start? He, as you can see, has had inner body fusions on multiple levels. He also has stenosis at L2-3, but you do see he kind of has some modic changes throughout. But the question is, are these actual modic changes vertebrogenic pain generators? Are these reactive changes from his hardware? So after looking at the T1 and T2, I looked at the STIR image, and around L5 and S1, it looked like there is still a ring of edema around the modic changes. So with seeing that and correlating it with his physical exam, what he was complaining of, decided to do BVNA at L5 and S1. Next slide. This is just more about his pain when I saw him. So when I saw him in the clinic, he was sitting forward with his elbows on his knees. So again, trying to not put pressure on his anterior column. He did have tenderness to palpation throughout his lumbar spine and his SI joints. Again, he did get relief with SI joint RFAs, but he had 5 out of 5 strength on muscle testing. He did have difficulty with sit to stand transfers, but he was also standing upright. So with him having good manual muscle good strength on manual muscle testing, sorry. And with him also standing upright, I was thinking, well, maybe his pain is less likely from the adjacent level stenosis in his back. Next slide. So his procedure was definitely more challenging with all the hardware. Typically, you'd like to do some pre-procedure planning with the MRI, but because of all the hardware, there's a lot of artifacts and difficult to do some really good preoperative planning. But I decided to enter on that right pedicle at L5 just because of the orientation of that screw. If you look at the orientation of the screw on the left side, it does seem to curve up, which would make it more difficult to get to the probe down to the middle of the AP level. Next slide. And then S1 was a lot more difficult. So during the procedure, once I squared off once I got Ferguson view and oblique to both sides, really didn't see good access to the pedicles there. So I decided to kind of do a modified sacroplasty approach to get to S1 and went in at S4 and carefully, incrementally going from AP and lateral, making sure my probe stayed in midline, was able to reach that S1 ablation zone. Next slide. So this patient, I was very guarded about how his outcome would be, but he ended up doing really well. He had 80% relief. He actually voluntarily reduced his opioid pain medications, which was huge. So I think kind of key takeaways from this procedure is really just expanding people's knowledge of vertebrogenic pain as a pain generator, especially with this patient. He said his pain started 30 years ago after he blew a disc out. So it kind of makes you think, if he was able to have the BVNA procedure before, would it have saved him from having 11 surgeries in his back? Would he have been saved from developing adjacent level stenosis? Would he have not developed sacroiliac joint pain? We won't know. There also needs to be research on BVNA outcomes on postoperative spines. Again, because is it actually vertebrogenic pain, or is it reactive changes from hardware in the spine? I think it'll be important to explore that, especially as a lot of insurance companies want BVNA to only be done on native levels in the lumbar spine. And then also just distinguishing discogenic pain and vertebrogenic pain. And I think by doing more research, hopefully we'll be able to expand access to this great treatment for our patients.
Thank you, Dr. Shia. And now we have Dr. Karen Patel, who is in her experience with that.
Hi there. Thank you so much for having me. Super excited. Wonderful presentations that preceded me here. Next slide, please. So we're going to dive right into some case presentations. So the first is a 68-year-old woman presenting after 12 years of chronic lower back pain. She had had multiple epidurals, medial branch blocks, radio frequency, with intermittent partial relief of those respective radicular symptoms and, posterior column symptoms. She continued to describe, despite these treatments, aching lower back pain, this pain that was worse with bending, sitting, and certain movements associated with her typical ADLs, such as moving clothes from a washer to a dryer, caring for her small dog that required frequent bending. In addition to the interventional treatment, she had also had conservative measures such as chiropractic, acupuncture, PT, and medications, neuropathics, and NSAIDs, namely. And she had actually even seen a neurosurgeon who had said that she was not a candidate for any type of spine surgery. She was referred by her pain management physician at NYU to see me over at Northwell for the BVNA procedure. Next slide. And so again, this was an extremely active, independent woman. Many of my patients in New York City fit this bill, where they're in 60s and above and they live independently and they're terrified about the idea of not being able to take care of their activities of daily living. She had midline lower back pain that was worse with, she said, with standing, sitting, and bending forward, but the symptoms were noticeably worse with forward flexion, such as activities in her that she described, such as moving the clothes from the washer to the dryer, feeding her, or taking care of her small dog, putting her shoes and socks on. One thing I like to do, I always tell my fellows that you want to look for the loudest voice in the room. What do I mean by that? I mean, like, the patient will have an MRI that shows a variety of different pathologies. And so the question is, which is the one that is limiting the patient the most? What is the first thing that we should try to address? And so in the exam room, when I see that there's an element of spinal stenosis, but then also vertebrogenic changes, I'll ask the patient to either sit the entire time and tell us when they feel uncomfortable, or stand the entire time. And so what I actually had her do was I had her stand the entire time to see just what she would do if I naturally saw her leaning or trying to sit down. I think it's an easy strategy to use when you're seeing patients without even having to have a conversation about it, until you realize whether they have more pain with sitting or standing. So her MRI, which was a new one that we obtained on the first visit, showed that there was a grade 1 enterolisthesis of L4, L5. There's moderate central canal stenosis at L4, L5, and type 2 modic changes at L4, L5, and S1. Next slide, please. And so here you can see that MRI, you can see that grade 1 enterolisthesis of 4 on 5, and then you can see the modic changes as well. Next slide. And so pre-procedural rather, her pain score was a 8 out of 10 in terms of her back pain. She could sit for 2 minutes before she would start to have pain, and she could stand upright in one spot for the whole 20 to 30-minute office visit that we had. And so we decided to perform BVNA at L4, L5, and S1. Next slide. So here you can see the procedural pictures. Now, I don't know if this was impressed upon you all in the audience in terms of, for those of you, many of you may be extremely familiar with the procedure and others may not be as familiar. So just to review the appropriate placement of where you should be creating your lesion. When we're talking about the lumbar levels, and again, on-label indications are from L3 to S1, we're talking about 50% between the superior and inferior end plate, and anywhere from about 40% to 30% from posterior, from the posterior to anterior on the lateral view. What's really important, very first step with any interventional procedure, when you're working at a particular spinal level, you want to make sure your end plates are sharp on that AP view. That's going to allow you to assess, if you haven't already done it pre-procedurally, which of the pedicles is really the one that you want to target. Again, we'll talk about in some subsequent slides about how you can use pre-procedural planning to help you with that so that you can be most efficient in your procedural time. But then also when you're on a lateral, you really want to limit the parallax. What do I mean by that? That means I want the foramen to be completely clear cut, and I want to see that the operative end plates that we're working at are extremely sharp. And that may involve putting some wigwag into your lateral view. Next slide. So again, this is the treatment here at L5. Again, looking to see that, if you pretend that the bipolar lesions are like sunglasses, we say the nose of the sunglass, we want directly on the spinous process. And again, that is based on the fact that you have a nice AP view and that you're looking at the spinous process equidistant between those pedicles. On the lateral view, again, looking to target 30 to 40% from the posterior end plate there. Next slide, please. And for S1, what's really important is that, understanding how to get that Ferguson view on the AP, but then also once you're moving over to lateral, that you are really truly seeing those iliopectineal lines superimposed. And that is, if you can make out that dark diagonal line on the lateral view there, that's what we are referring to when we talk about iliopectineal lines being superimposed. Next slide. So here, this patient did great. At the post-op visit, 2 weeks, I typically have my patients come back 2 weeks after the procedure. And I say there are patients who are going to respond right away. There are patients who it may take up to 2 weeks or 4 weeks, and then after that, if somebody hasn't responded by 3 months, they're likely not to get an improvement from that procedure. And that's how I'd like to lay expectations. This patient was able, after the procedure, to sit without pain and to bend forward without issue, care for their dog, put on their shoes and socks easily. I always like to ask, when did you notice that you were starting to feel better? And for her, she said 1 week following her procedure. Overall, happy patient. All of her pre-procedural goals were attained. Next slide. So case 4, 52-year-old gentleman presenting after 8 years of chronic lower back pain, had multiple epidurals, branch blocks, RFA for both, respective radicular and posterior column pain symptoms, had continued pain with flexion. Also had lower back pain that was worse with bending, sitting, ADLs. He had actually worked as a carpenter and had significant pain with a lot of the movements required in his job. He had gone to chiropractor, acupuncture, PT, had some medications, and even had seen a surgeon. The surgeons had actually offered him surgery, and I'll show you why. And you can understand why many people might. He was referred by his neighbor, who was actually one of my patients, and had a positive response with BVNA. Next slide. So patient had midline lower back pain with standing, sitting, and bending forward. Symptoms were noticeably worse with forward flexion. And this was, evidenced in his life when he was bending and lifting, required to perform his job as a carpenter, but then also with sitting and driving. His wife was also my patient, and she was saying that their social life had gone to nil because he didn't feel comfortable driving any farther away than 20 minutes. He also liked to do a lot of yard work, and was a really nice guy, would actually take care of the yard work for his neighbors, and obviously involved with a lot of physical activities and doing that. And he had difficulty tying his shoes with that flexion movement. His exam was consistent with all this. He had minor pain with extension, and this was following his lumbar RFA, and did not have any signs of weakness on physical exam. We did get an MRI, obviously. It showed grade 1 enterolisthesis of L5 S1. I think when we look at it, we'll probably call it maybe a grade 1.5, maybe even closer to a 2. And so he had significant disc degeneration at L5 S1 and foraminal compression, as well as type 2 motor changes at L5 and S1. So anytime, I'm in the practice where if I'm ordering somebody's MRI, I'm also ordering flexion extension x-rays. And I think that's a great habit for all of you to get into. One, because it's going to allow you, if you do discover that they have an enterolisthesis, one, you're going to understand if there's any type of dynamic instability, but also if you see fluid in the facet joints, that might explain that there could be potentially some movement there as well that you should explore. Next slide. So here, this is the enterolisthesis that I'm speaking of. And again, those type 2 modic changes you can see at the end plates of L5, the inferior end plate, and the superior end plate of S1. Next slide. And these were those flexion extension x-rays with actually a fixed minimal movement. And again, this was a patient who had been offered fusion surgery. You know, we were able to manage his posterior column pain symptoms with radio frequency ablations. And then this anterior column symptoms, we offered him, next slide, not a big surprise. We offered him basic vertebral nerve ablation at both L5 and S1. And you can see, you know, as we know, his pain was significantly limiting the scope of his life. Next slide. So again, here, if you can imagine, you know, you see that the black portion of the probe there, we see that's one lens of a pair of sunglasses, and you can imagine the opposite side, or you can see the outline of it. We want the nose of those sunglasses over the spinous process, right? And really wanting to target that posterior 30% to 40% to really get kind of the root of the basic vertebral nerve. Next slide. Actually, go back one slide if you can. So if you see those lines across the sacrum there, you can see how they're separated. They almost look like parallel railroad tracks. Now remember, these views are for the L5 level. So we've sharpened up the end plates on both the lateral and the AP to really look at the L5 vertebral body. But if we go to the next slide, we've then adjusted our waggle on the lateral view, and you can see that those railroad tracks are now more superimposed. That's what I mean about really superimposing the iliopectineal lines. And that's how you know you're looking at a true lateral on the sacrum. And that's really important, because you could be working on L5 and it's going to look totally different when you're working on S1. Next slide. So this patient did great at his 4-week visit. He had a 1 out of 10 pain, overall 90% pain improvement, able to bend forward without pain, able to drive. His wife said he had no more excuses for getting out of these social settings, able to, you know, really kind of throw himself fully into his work as a carpenter and cabinet maker, and was able to return to his yard working and gardening. And for him, he said he felt better after 2 weeks. So, you know, interesting. The first patient said 1 week. This patient said 2 weeks. It's going to vary. Overall, patient was happy. All of their pre-procedural goals were attained. Next slide. So now we're going to dive into some of those pearls, meaning, you know, what are the things that you should think about as you're moving from fellowship and are passing through the young phases of your career, you know, and learning to adapt a new therapy into your practice. So I think one of the things that's most important is being efficient with your procedural room time. And so one thing that with basic vertebral nerve ablation that can help you very much is if you actually map out the entry trajectory an angle into the pedicle and the vertebral body. This can be done by mapping a line on the axials that start at the anteromedial aspect of the pedicle and then extends through the posterior lateral aspect of the pedicle, and then extending further to the skin. This can really allow you to, you know, be most confident and efficient with your angle of approach. Next slide. So some challenges you may see. You know, my colleague Dr. Padilla just described, you know, the idea of looking at pedicles and trying to decide which area place you want to enter. You know, sometimes the pedicles on both sides are going to be narrow. And so the way to really deal with that is to have had some forethought in your pre-op planning. And then also while you are, you know, docking on the pedicle, making sure that you are taking multiple images, both in the AP and lateral view. You know, just understanding that the fact that it's a narrow pedicle, you may need to use a little bit more imaging just to make sure that you're in the safety zones. How do you deal with hard bone? Well, again, you want to take more images often because you want to avoid the cortex of the pedicle. And you may need to, at some point, realize that you might need a little bit more force in order to pass through hard bone, particularly if they're a younger patient. And you may even want to make use of a drill that is typically included in the procedural kit. If you're dealing with multiple levels, and in most cases you're going to be doing multiple levels, it is thought to easily start on the left. You know, particularly if you're obviously convention is to stand on the left side of the patient, and then you want to finish on the right. And the reason that is because you can avoid the C-arm moving, potentially, dislodging a probe or moving a probe while you're, if you're finished one level. If you had started on the right side and then you go to do the next level on the left side, there's an increased chance that as you're moving from, either the oblique to the AP and then to the lateral, you may actually inadvertently, dislodge or move the probe. And that's not something obviously you'd want to do. How do you deal with a high riding pelvis? Well, again, a lot of pre-op planning, to decide which side you want to start with or approach first. And typically, what we see is that one iliac crest is a little bit higher than the other. And when it's more oblique, that's where you want to go. Now, that being said, you want to use an oblique approach, but you want to be very sure not to violate the cortex of the iliac crest. So it's finding that balance of how you best can get into your docking position on the sacrum. In terms of minimizing post-op pain, something I do definitely is I use a finder needle, and I use that to anesthetize the pedicle. Other individuals, this isn't something that I do, but they will have described that they'll do if they have 3 levels, at that middle level, they'll do an interlaminar epidural, potentially to prevent neuritis post-operatively. Again, that's a rare indication, a rare outcome of this procedure, but if you are careful and mindful of how you enter and you're making sure, that once you are approaching kind of the middle region of the pedicle on the lateral view, that you're switching to that AP. And what you can often do is turn the instrument such that the arrows are pointing out, and you can see if you still have that safety zone to know that you have not violated the medial border of the pedicle. Next slide. So these are some things I can't impress upon you enough. You really want to look at your own MRIs here, meaning you want to look at all of the sagittal views. You want to scroll through, right, and look at every single vertebral level carefully and make sure that you are adequately understanding, if you are seeing type 1 and type 2 modic, and make sure that you're not treating sclerotic bone or type 3, because the basivertebral nerve ablation is not indicated for type 3 modic changes. You also want to make sure that, if you're taking the patient to the OR and you're treating them for 2 levels, that you're not missing modic changes at other levels that may be involved in the pain that they're experiencing. You also want to anticipate any anatomical challenges. If you know that a patient has a scoliosis, you want to see what that looks like. And looking at your preoperative images is very important in doing that. Again, I can't impress upon you how important it is to start with the procedural level, start with those end plates being very sharp on an AP, and when you move to a lateral view, insist that it is an accurate lateral. What do I mean by that? There's no parallax. You can see a clear delineated outline of the foramen. You can see that the end plates are very sharp at the procedural level. And then when we're talking about the sacrum, again, we're looking for those iliopectineal lines to be lined up. I always say measure twice, cut once. I say when you're first doing this procedure, particularly when you're doing your first cases on your own, use a finder needle. What do I mean by that? Start in the oblique view, right? You're trying to put that facet joint at the 50% line of the end plate, okay? And at that point, then your needle entry is probably going to be at the eye of the Scotty dog, and you're going to dock your needle where you're going to dock your trocar, which is in the center of the pedicle. So once you've placed your finder needle, then see where it looks on on an AP view, and then go lateral and see where it looks. And as soon as you have that finder needle in the position that you would want the trocar to be in, that gives you confidence, so that when you go back to that oblique view where the facet joint is at the 50% line, you're able to give your local, make your stab incision, go down with your trocar, and feel confident that you're in a good position to dock. The other reason that you want to use a finder needle potentially is because the surface of a pedicle is not flat. It's kind of like walking on the moon. And so there can be a lot of variations to the texture of it that you're not able to appreciate based on, looking at an MRI or looking even at an X-ray. So it's a lot of it is the tactile feel, and that the finder needle gives you the ability to kind of investigate that without making a major commitment. Because if you're docking multiple times on the pedicle, you can actually kind of create, almost like Swiss cheese, right? Where it's hard to finally dock in the position that you want. And if you use the finer needle, you may find that fewer times that you'll have to abort and go to the opposite pedicle. And I can't say this enough. You want to treat the loudest voice in the room. What does that mean? If you have a patient who has an element of spinal stenosis, has an element of vertebrogenic pain, has some facetogenic pain, when you first see them, what is the loudest voice in the room? Is it the pain with extension, or is it the pain with flexion, or is it their inability to stand and walk for long periods of time? Treat those symptoms first, or tell the patient that you have multiple pathologies within your spine, and try to explain to them that the different pathologies give them different symptoms. And so that explaining, we are addressing your vertebrogenic changes, therefore that's going to help with the pain that you have when you sit, when you bend, when you reach. It's not going to help with the pain that you may have when you stand and when you walk. That's probably your neurogenic claudication from the spinal stenosis. Next slide. So this is really important. It's a QR code. It'll take you to a copy of the guidelines right now. Look, it starts very simply. 6 months of chronic lower back pain, failing conservative measures. You want to, decide, is this an anterior column pain, or is this a middle or posterior column pain, right? Is this somebody who has symptoms of neurogenic claudication, or somebody who has symptoms of pain with extension and rotation, where we might think it might be more facetogenic? Or is it pain, with flexion? And then you want to obviously look at your imaging and see if you see any types of type 1 or 2 modic or enhancing Schmorl's nodes. You don't want to just treat, Schmorl's nodes that are there. They need to be those nodes which are actually enhancing. If you do not see any modic changes, or you do not see any enhancing Schmorl's nodes, and or there is modic 3, you need to think about other therapies, potentially maybe an intradiscal therapy or an alternative therapy. But if you do see, the type 1, type 2 modic and enhancing enhancing Schmorl's node, those are the patients who are going to be candidates for basivertebral nerve ablation. Next slide. That's it. And with that, we'll open it up to questions.
Thank you so much, Dr. Patel, for a wonderful presentation. I always walk away having learned something new about basivertebral. So let's just jump into questions. We don't have too much time, so I would ask all the panelists to turn back on their cameras, as the first question is geared towards our young panelist, Dr. Janeja, Dr. Moreira. I challenge you in 60 seconds or less, tell me, how have the Aspen basivertebral guidelines helped you thus far in your career? Start with Dr. Moreira.
Hearing a little bit of feedback there on your, I'm not sure what's going on. But yeah, so as far as patient selection is really narrowed down, the key buzzwords like sitting intolerance, that kind of thing, and kind of teasing out whether like Dr. Paul mentioned earlier, that the modic changes and the patient selection, those are key for finding these patients in our practices, and just being more cognizant of that. So I've seen, I've heard also, like in our clinic setting, almost as like a salvage for SCS, if they've have had multiple different treatments, and finally, discovering, this etiology subset of chronic low back pain that's hard to treat, being from vertebrogenic source. I've seen that during fellowship this year at Rush, in our clinical practice. These patients are, staring us right in front of us, like not even just new patients, but patients that we've seen for multiple years, essentially. And so it's easy to kind of forget about this this awesome therapy.
Thank Thank you. And can I just have all the panelists just mute their mic real quick to prevent more feedback? Thank you. I appreciate that. So let's also try to answer some of the questions we have in the chat as well to give some of these questions an answer. So
absolutely.
If anyone, go ahead.
Yeah, absolutely. So we had a couple of questions here in the chat box. I'm going to just read out, and maybe all the panelists, maybe perhaps Dr. Patel and Dr. Padilla can chime in, since these are more clinically relevant questions here, and you might chime in with your experience. So one attendee is asking about modic changes have been previously regarded as low-grade infection with recommendation for antibiotics to cure. What's your take on that compared to doing a procedure such as basivertebral nerve ablation? So BVN ablation versus potentially antibiotics, given that there's a concern for low-grade infection as modic in the setting of modic changes.
So I can take that. So the use of antibiotics for treating modic changes when they're are seen at the vertebral end plates has been a debate over multiple years. And so initial studies, the research actually suggested that a 100-day course of broad spectrum antibiotics might be effective for treating modic changes. And this was really this Propionibacterium acnes, which was the bug that they thought was associated with it. And so they thought broad spectrum antibiotics would help it. However, this was then followed by multiple years, including the AIM study, which actually showed mixed outcomes, that that there wasn't a significant benefit of even 3-month treatment of antibiotics with amoxicillin for those patients who had modic changes. And so obviously there's concerns about, using 100 days or more of antibiotics in terms of, contributing to gastrointestinal side effects and then antibiotic resistance. And we're not even sure about the evidence that supports the infection hypothesis. So the question really is, the data that supports this infectious kind of concept isn't extremely strong. But what we do see is all of the evidence showing how much more greatly and biologically active the vertebral end plates are after there's disc rupture, and we have this cytokine upregulation of kind of the porous substance at the vertebral end plates, and how we kind of see that patients can actually go in and out of type 1 and type 2 modic, and it's biologically active, and that the end plates, much more than the disc, are highly innervated. So for me, given the level of evidence that we have in terms of the 5-year data that's published, and now potentially even 7, I really do think that if you see modic changes and you're inclined to treat them, there's much more evidence that's out there supporting a basivertebral nerve ablation approach as opposed to antibiotic approach, unless
Absolutely.
there is a known infection of the vertebral bodies, which is totally separate.
Sure, absolutely. Well, thanks for sharing that. And that goes along the guidelines that we discussed today with Aspen giving that grade A evidence for basivertebral nerve ablation. A couple other questions that we had in the chat that were about doing the procedure bilaterally, and I think that was addressed during the procedure aspect that you do unilaterally, and then you can also go, it's from L3 to S1, and that's the approved FDA indication. However, off-label, that could be a different approach. You can go higher than that off-label, but technically FDA is just L3 to S1. Do we have more questions? Time for questions? I think we are at 7:01, so that might be all the time that we had for questions today. With that being said, we'd like to thank everybody for joining us today, all the panelists. Excellent work by everybody. Appreciate all the insight. Thank you for all our attendees. We had a great number of people participating today. I want to make sure that you are aware, hopefully you are, and we'll see you in Miami for our annual conference in July, July 17 to July 20. Please register. You can scan the QR code. We have an excellent faculty line up for the lab as well as for our lectures. And we'll be in London as well in October. So hopefully we'll be able to see you there for our second international meeting for ISPN. Which will be in London in October. Thank you everybody for joining us, and we'll look forward to seeing you for the next Journal Club in a few months. Thank you.
Everyone, good night.